Thank you again for joining us. My name is Matthew Menendez with White Plume, and we're going to be talking this webinar exclusively for orthopedic practices. We do a lot of work with orthopedic practices across the country, and we wanted to share kind of what we see as some of the key revenue cycle trends and insights as we progress through 2019. Just a quick overview of what we hope to accomplish over the next 50 minutes or so. I'm going to spend a little bit of time at the beginning talking about the realities that we see, some of the revenue cycle trends that started to emerge in 2018 and are really picking up steam in 2019. So a couple of things to mention there that we think will really have an impact on the revenue cycle. What we see is a reality is that revenue cycle teams are spending more time doing more work for the same reimbursement, sometimes even less. And they're also dealing with fewer resources from an FTE perspective, with some turnover that's associated with that. That makes for a very difficult environment for orthopedic practices and practice leaders to be successful in their revenue cycle team. Now, I know all of this sounds like bad news. I don't want to be all doom and gloom this afternoon, because I am optimistic. Our industry has a lot of creative and innovative people in it, and we are fortunate to work with a lot of revenue cycle leaders who have come up with some brilliant strategies and very sound tactics to deal with these new realities. These trailblazers are showing us a path forward as to how we can help improve coder productivity, coding accuracy, and revenue cycle outcomes. So the second piece that I want to share and focus on is the response to what we're seeing from some of these top performers. What are they doing that sets them apart? Because it's not magic. It's certainly replicable over other practices. So we want to share some of that feedback. And what we think, after you look at the reality and the response, what we see are the results. What's happening in 2019 is this growing gap, this growing performance gap between the top performers and the average practice, right? The rich are getting richer, the poor are getting poorer, and we want to make sure that you and your practice can be in that former group, the rich that are getting richer, right? So we're going to talk through all of that today. I'll make sure that we leave time for questions and answers at the end. So feel free to use the questions panel to communicate with us during the webinar today, and we will try to answer all of those questions as we go, and certainly share some of the most broadly applicable questions for everybody at the end. Okay? So we're going to talk about the reality, then we're going to talk about the response, how top performers are responding to those challenges, and then we're going to talk a little bit about the results, what that growing performance gap looks like, and how your practice can make sure you're on the right side of it. So let's talk about the reality. What are these emerging revenue cycle trends? I want to start off by talking about more work for billers and coders. We see that in a couple of different areas. The three that I'm going to spend time focusing on are prior authorizations, HCC and risk-adjusted coding, and then patient AR work on the back end. We'll talk about all three of those and drill down into a little bit more detail. The second revenue cycle trend that we see as a challenge is flat reimbursement rates from payers. Certainly, this is led off by Medicare, and a lot of the commercial carriers follow suit, but you're seeing them shift some of their focus away from fee-for-service to value-based care. A lot of that's happening through QPP and MIPS, but there haven't been a lot of additional revenue opportunities there for orthopedic practices either. Finally, is the CMS proposed change to the way that E&M payments are reimbursed. We'll talk through that. That's been pushed off for a number of years. And then the last area, the third area of challenges that we'll drill down and look at in detail is coding and billing staff turnover, right? We are in a very, very tight labor market. Unemployment is at a 60-year low right now, and we expect to see a lot of turnover and a lot of growth in the coding and billing staffing over the next 4, 5, 6 years. That means if you do have turnover, it's very difficult to go out and find those new employees. They're working for somebody else today. That means you're going to have to hire them away from someone typically. All right, so we're going to jump into all three of those areas and look at those emerging trends, look at those realities that make the revenue cycle process difficult for orthopedic practices. All right, so we'll look at each one individually. First, let's look at the additional work for billers and coders. I mentioned this before. We see three key areas that orthopedic practices are struggling and that they're putting some of this work onto their billing and coding team. Number one is prior authorizations. Number two, HCC and risk-adjusted coding. Maybe not just in your total knee replacements, but starting to creep into other lines of business as well. And then the last one is the continuing trend of patients' accounts receivable increasing and being more difficult to collect as more and more of our patients are moving to high deductible health plans. So we'll look at each of those in turn. First, prior authorization. From a clinical impact perspective, it can delay patient care. When you're jumping through all the hoops that the payers are requiring, it can delay a patient being approved for an MRI, being approved for a procedure, because basically prior authorizations are the new denial, right? They used to deny a claim on the back end. Now they're making you pre-adjudicate that claim in a sense by getting a prior authorization and denying it on the front end, right? On average, this is happening 29 times per week per physician. So from a workload perspective, you can see a significant increase in the amount of time that's required dealing with payer headaches on the front end of the revenue cycle process. Now, what we see is a lot of practices are trying to offload this work, and they're looking in the natural place to do that is to their billing and coding team. These are the resources that are most familiar with complex payer requirements. They're most familiar with jumping through those hoops and making sure they get those things approved. And it's much better to have coder or biller resources spending that time, obviously, than having your surgeons or your non-surgical providers spending that time working back and forth with the payers. But the bad news is that means for your team, they're spending additional hours per week, and it's not like they were sitting around twiddling their thumbs, right? They're having to spend that time before the patient has ever been seen, and it's taking up significant resources. So when we look at emerging trends that are causing more work for the billing and coding team, for a lot of people, prior authorizations is at the top of the list. The next area that we see emerging in orthopedic practices across the country is HCC and risk-adjusted coding. Now, some of you may be very familiar with this and have a lot of expertise. Some of you, this may be brand new, or you may be a relative novice at this. So I'll give you just a little bit of information on that. If you've got more questions, feel free to reach out. We can provide a lot more content and educational resources around HCC and risk-adjusted coding when you're ready for that. But at a very high level, what's happening here is Medicare and other commercial payers have very clearly been saying that they want to shift reimbursement from fee-for-service to reimbursement that's based on quality outcomes and cost-effectiveness, right? That's been going on for years. That's the basis of the Medicare Advantage program, right? That's the basis for the value-based modifier. That's a lot of what's going on with MIPS. But the frustration from the physician community has always been, you don't understand. My patients are much sicker than everybody else's. And that cannot be true across the board. Everybody cannot be treating the sickest patients. So with the HCC and risk-adjusted coding programs, Medicare is telling you, fine, we will adjust your quality measures. We will adjust your cost measures based on the acuity of your patients, but you have to prove how sick they are. And HCC is the preferred risk-adjusted methodology that is used by Medicare and commercial carriers to measure how sick your patients are, right? They very kind of fundamental level, what HCC and risk-adjusted coding is trying to do is it's looking at and trying to quantify how sick your patients or your patient population is. It does that with two factors. One part is your patient demographics. The second part is your patient diagnoses. Demographics are things like age, gender, community living status. Are they living independently? Are they living in a nursing home? Are they disabled? Were they aged into the Medicare program? Questions like that, that you can't change. That is what it is. But the diagnosis component looks at how sick your patient is and adds additional points or value to that patient HCC score. And where we see a lot of people making mistakes is when they are not coding and documenting patient comorbidities. That's what HCC and risk-adjusted coding is all about. And obviously you can see where that puts work on the coding and billing teams to get that right downstream for the physician without turning the doctor into a coder. So we see that as the second place that a lot of orthopedic practices are starting to see additional requirements, additional work being put on their billing and coding teams. And the third and final place that we see that trend emerging is in patient accounts receivable, right? Based on HHS information, 43.4% of United States households in 2017, which is the most recent year they've published data, were on high deductible health plans. And that means that the average deductible for the average family in the United States is now $2,600. Probably a little bit outdated and probably a little bit higher now. And what that means is when you look at the stats on how practices are able to collect from patients, that means you're doing a lot more work to follow up, get those dollars collected. That means that we will probably in 2019 go over the tipping point where more of your patients will be on high deductible health plans than non-high deductible health plans. Certainly that depends on your patient population mix. Certainly that depends on what payers are in your state and what those trends look like locally, right? But when we look across the board, we see that as another large trend. And again, it takes more billing resources to collect from a patient than it does to collect from a health insurer. So when we look at the landscape and say one of the major trends is that your billers and coders are typically being asked to do more, these are some of the three big areas that we see in orthopedic practices are having a major impact. So with that being said, let me launch our first poll question. And this poll is one where you can select multiple options. So the question is, which areas are you seeing more work for your billers and coders? All you need to do is check each one that you think applies in your practice and then hit submit. I'll share the results kind of with you as we go. I'll give you probably another 15, 20 seconds to lock in those polling answers. So what we see, just to give you kind of an idea, number one answer across the board is up at prior authorizations. We're seeing 75–80% of orthopedic practices are saying that they're seeing more work on that front for their billers and coders, but that's closely followed by patient accounts receivable. 65–70% of the orthopedic practices are saying that they are seeing more work for billers and coders on that front, and then about 20%, 25% struggling with the HCC and risk-adjusted coding. That's about what we expect. A lot of, about 20% of practices have risk-adjusted contracts, so that's about in line. If you're not seeing that one yet in your area, you might see that over the next 2, 3, 4 years. So we want to remember we're talking about the difficult realities that orthopedic practices face from a revenue cycle perspective. The first challenge was more work for billers and coders. The second challenge is flat reimbursement rates, right? Let's look at this. Again, we'll look at three areas where flat reimbursement rates are impacting orthopedic practices. The first one is modest fee-for-service increases. If you look at that over time, it is basically flat, particularly when you look at that compared to inflation over the same period of time. The second area are tiny MIPS bonuses. Medicare is focusing a lot of their time and attention on QPP. For most of you, that ends up being under kind of the MIPS umbrella. So they're diverting dollars away from fee-for-service, trying to put that into MIPS. But one of the things that we're seeing is there aren't a lot of dollars available for practices under the MIPS program, or much less than people originally thought, because there haven't been very many people paying the penalty. I'll walk through that portion of it for you as well. The third piece are some of the proposed changes to E&M payments. We'll talk through that as well. That's a change that has actually been pushed out for a couple of years, but I want to make sure everybody's prepared for that when it does come up. So let's talk about those fee-for-service increases first. If you look at this graph under the orange line, what you see, the orange line shows you the fee-for-service increases over the last 10 years, right? And you can see those have been single-digit increases at best. But the green line is what's happened to inflation over the same period of time. So what that means for most practices is your cost of supplies, your cost of rent, your cost for employees, your cost for insurance have all gone up while your reimbursement has basically stayed flat. So when you adjust for inflation, it actually ends up being a net decrease to your reimbursement rather than a net increase in your reimbursement over the last 10 years. You probably feel that. Budgets are probably tighter. It's really frustrating to be doing the same work, and in a lot of cases more, for a lower reimbursement rate, right? So we look at that and say, all right, we've got some real challenges there. Maybe there are additional dollars available through that NIPS or QPP program, but that's the second area that I wanted to talk about. If you remember, and again, if you need more detail, happy to supply this. We've got an entire webinar that talks about reimbursement under MIPS. But the way that MIPS works is everybody is graded on a curve. Every practice, every eligible clinician will get a score between 0 and 100. And if you don't score well, if you don't cross that performance threshold, then you'll get a negative adjustment or a penalty on your Medicare reimbursement. If you do score better than that performance threshold, you can get a positive adjustment or a bonus. But the important distinction to remember is under MIPS, it is a revenue-neutral program for Medicare. It is a revenue-neutral program for Medicare. And what that means is the government is not funding this program. It is simply a transfer payment. Medicare takes money away from the doctors who do not score well, and they give those same dollars to the doctors who do score well. They are taking money from the losers and giving it to the winners, right? They are the house, except for a temporary pool of dollars that are set aside for the exceptional performance threshold, right? So what that means is if you look at the first couple of years of reporting of what's happened in MIPS so far, is that they set that performance threshold so low that not many people failed. If everybody was successful, that means there weren't a lot of available dollars to distribute to the people who did well. So the average bonus paid to groups who did not exceed that exceptional performance threshold was 0.3%, right? Probably not the work, probably not worth the level of effort that you had to put in, even to report all of the data, right? So we looked at two areas so far. Number one, fee-for-service reimbursement. Number two, changes under MIPS, looking at those bonus payments that were available. The third area were this proposed change to E&M payments. Right now, CMS has delayed this change because it would have impacted physician reimbursement. But in mid-2018, CMS proposed a major change to E&M coding in an effort to simplify documentation requirements for physicians. They were trying to fight back against that physician burnout that we read against so frequently, right? The change was going to reduce the documentation requirements that were necessary to differentiate between levels of service for new and established outpatient visits. Right? Now, this is not for your surgeries, it's not for your big dollar items, but it still makes a difference on those E&M codes. And so many physician advocacy groups really applauded the effort because it would reduce physician documentation requirements of what was happening inside the EHR, right? So that they could reduce the amount of time physicians spent documenting in their EHR. But for many practices, obviously the devil's in the details when they look at these reimbursement changes. So what you can see here in this graphic is that they were going to collapse 5 different levels of service into essentially 2, right? They'd pay you more for a 99211 under the new plan. They'd pay you more for what used to be a 99212 and used to be a 99213, but they'd pay you a little bit less for what used to be a level 4 and what used to be a level 5, right? And so, but when you actually do the math, and don't worry, I'm not going to ask you to do it. I've done it for you. When you actually do the math and say, okay, let's assume a distribution of our E&M codes that looks like a bell curve of what you would expect to see, you can see the total reimbursement actually goes down, right? You did better in the level 1 and level 2 and level 3, but you did worse in the level 4 and the worse in the level 5. And those are more than 50% of your office visits. Therefore, your total reimbursement for E&M codes goes down. Now, for an orthopedic practice, I realize this is not where our bread is buttered, but when you look at the primary care physicians, they had a significant problem with that, right? It's actually a net decrease of about a half a percentage point. So as a result of that, you had a lot of physician professional associations asking CMS to delay these types of changes. And in November, CMS actually announced that this policy would not be implemented till 2021. So I suspect you'll start to hear a little bit more about that again in 2020, and you'll probably have some of those same advocacy groups asking them to push it back again. Sounds kind of like ICD-10 to me. So we look at all those areas and say, okay, here's what we see. We see flat reimbursement rates. Because of the fee-for-service change, the conversion factor is a small increase, but costs are going up even more. So we're really kind of a net negative from a fee-for-service reimbursement perspective. And most commercial payers are following Medicare's lead on this. Another opportunity for additional revenue growth was in the QPP, right? Good news is very few practices are paying the penalty. The bad news is that means there aren't very many dollars available to pay out to bonuses for people who have done well. So that's not really a good new revenue opportunity for most groups. And then when I look at those proposed changes to E&M payments, it sounds nice, like it might relieve some of the burden from a documentation perspective on my physicians, but the risk of a payment reduction, that's kind of robbing Peter to pay Paul. Yep, it saved me a little bit of time, but it's taking away some of my money. So I'm kind of glad for practices that's delayed until 2021. So when we're looking at the reality of what's difficult, what are the trends that orthopedic practices are pushing against? We've talked about number 1, more work for billers and coders. We've talked about number 2, flat reimbursement rates. And the third area is really for practice leadership. So this is for the administrator, for the CEO, for the billing manager, for the revenue cycle director. We're seeing challenges in the revenue cycle staffing perspective. The first thing is we are at an all-time low, at least in the past 50 years now, not just a 10-year low anymore, a 50-year low in unemployment. And that means that the best people, the people that you want on your team, the majority of them are working for somebody else today. Right? And what that means is it's going to make those people more expensive to hire. They're working for somebody else. You've got to assume that they are at least relatively happy. You're probably going to have to pay them more in order to get them to come on board. So it means you're hiring them away from another practice or hiring them away from a hospital system in town. Right? So low unemployment makes it hard when you have to hire billing staff. The second area that works against you in that is that there is a growing demand for both billers and coders. We're seeing that in a couple of different places. Number 1, when you look at the National Leadership Resource Board, billing and coding jobs are projected to increase by 13% over the next 5 years. 13% over the next 5 years. That tells us there's going to be a labor shortage for billers and coders, particularly if you want to find somebody that has some experience. And you have other people that are coming in, getting into this market that are trying to hire these same people. You've got EHR companies that are switching to service-based organizations that are starting up their own RCM shops. They need to hire billers and coders. You have revenue cycle companies that are continuing to grow, continuing to expand, that are allowing billers and coders to work from home and paying them well to do that. And you certainly have hospitals in town who continue to grow through acquisition and need more billers and coders on their team. So there's not a lot of people sitting on the sidelines looking for a job right now, number one. Number two, on the demand side, you have a lot of employers that are looking for this talent, and that'll continue to be the case for the next 5 years. Both of those variables push up the salary requirements for billing and coding teams, right? And as a manager, as a leader, the amount of time that you have to spend to recruit and train and deploy a new biller, a new coder, is costly, right? Think about it this way, and I hope this certainly doesn't happen to anybody on the call today, but if your best coder turned in their notice today, how long would it take you to identify, interview, hire, onboard, and train that person, that new person, to where they were as productive as the person who just left? How long would that take? When you look at that, it's not a good picture. It's not a good picture. And so we'll talk about some of the responses that we see these top performers employing to push back against this. But the second polling question that I wanted to kind of put in front of the group today is, think about your practice. And 12 months from now, how many billers and coders do you expect to have at this time next year? You can only choose one answer on this one. But do you expect to have the same number with the exact same people in place? Or do you expect to have the same number of positions, but you probably have to turn over and replace an employee or two? Or do you expect to have fewer billers and coders than you do today? Or do you expect to have more billers and coders than you do today? Go ahead, lock in your answers. I'll give you about 10 more seconds or so to go ahead and complete that. And thank you guys for participating. It's always fun to see these numbers come in and to share them with you. Hopefully this is helpful for everybody. But what we see, if I'm combining the results from the two webinars at the top of my head, we saw about close to 3/4 expected to have some turnover in their practice, right? Either sticking with the same number of billers and coders or having additional billers and coders that they need to bring on board. So when you think about that, in the orthopedic space, your colleagues across the country, 3/4 of them expect to be hiring a biller or coder in the next 12 months in a very difficult environment to find that type of talent, right? These are trends that we need to be thinking about so that we can get out ahead of rather than responding in a moment of crisis. So we said the first part of the webinar, we were going to talk about the realities, the challenges that orthopedic practices face in their revenue cycle, trying to deliver the excellent outcomes that their doctors and practices require. And the three big challenges that we see are billers and coders are asking to do more work. There's more on their plate for them to do. At the same time, reimbursement rates are flat or slightly down when you adjust for inflation. And managers and leaders are struggling to fill open positions and having to pay more for those same staff positions than they did before. Very tight labor market, very high demand, and that will continue over the next 4 or 5 years. Now, I know that sounds all like bad news, right? And there are significant headwinds out there in our industry. But the good news is there are a lot of people who are doing very good work. A lot of orthopedic practices that we have the pleasure of working with that are very innovative, that are very creative in their workflows, and they're finding ways to make their team more productive. Now, I'm going to talk about 3 big categories, and then we'll talk about some details underneath each of these categories in the second half of the webinar. The first secret that we see top performing practices putting into place, their first response is to leverage their existing platforms. The meaningful use era is over. We are not seeing a lot of people that are jumping into the replacement market. Close to 70% of physician practices expect to keep their current EHR, and they're looking for ways to improve their EHR. They're looking for ways to improve their PM system, looking for additional solutions to make those processes work better. And I think that's brilliant. I think that makes a lot of sense rather than going through the headache and heartache of ripping and replacing an old system and putting in a new system that may or may not be that different. So I think that is the #1 strategy we see practices putting into place. Now, after they do that, these top performing orthopedic practices are looking at analytics. They're looking at data in their revenue cycle, and they're going beyond some of the traditional metrics of denial rate or accounts receivable days. And they're starting to ask questions like this. They're starting to say, we've got an excellent denial rate, 2, 3, 4%. But how many resources are we investing in to deliver that type of low denial rate? How productive are my coders? What types of changes are they having to make for our doctors? How many changes are they making? They're starting to ask those types of questions so that they've got visibility into the process, not just visibility into the back-end outcome. And that allows them to drive better performance by their team and a lower denial rate and a lower mischarge rate. So those analytics are very, very powerful for top performing orthopedic practices who are able to get their hands on that type of data. And then the third thing that they do after they've got those types of analytics tools in place is they're able to actually automate some of the mundane parts of their billing and coding process. Right? They're able to look for opportunities where the coder doesn't have to touch that particular encounter, but it can still go out the door completely and correctly the first time. So the response that we see from top performing orthopedic practices are #1, leverage the existing platform, #2, revenue cycle analytics, and #3, revenue cycle automation. When you put all three of those things together, that can be a very, very powerful tool for these types of practices. So let me show you what we see in the first one, get into a little bit more detail on how these groups are leveraging their existing EHR and PM platforms. The first insight here is that the meaningful use era is over, right? We all lived through that, roughly 2009 to 2015. EHR adoption more than doubled during that period of time, going from 42% to almost 90%. The market is fully saturated. Everybody who is going to buy an EHR has already done it. The new EHR sales opportunities are very, very small. But surprisingly, there's also a very low EHR replacement rate. You read some of the Wall Street analysts that are following these publicly traded EHR companies. A lot of the publicly traded EHR companies expected there to be a second bite of the apple, is what they called it. They expected a lot of practices to switch their EHR system after they implemented their first one. But what we saw is that really hasn't happened. Even with moderate satisfaction at best for most EHR systems, right? There are very few practices who just love their EHR. But why are there so few that actually change systems? And I believe that most practices and most top performing practices, they're making an honest calculation that says, despite our frustration with our incumbent EHR, any new vendor may not be significantly better at all, right? It's the devil I know versus the devil I don't. And so the switch that we've seen after the meaningful use era, after the ICD-10 era, is these top performing practices, what they're doing is they're looking for opportunities to improve their existing EHR, right? They think that there is a better return on investment from system optimization than there is from ripping and replacing and going through the downtime and the training time and the dollars required to bring in a new EHR. It just makes more financial and practical sense to leverage the existing platform than to rip and replace a new EHR or PM platform. And when practices start looking for opportunities to improve efficiencies within their practice, within their existing platforms, the revenue cycle is a low-hanging fruit opportunity, right? We always thought, people always expected that meaningful use was going to kind of fully automate and make the revenue cycle just sing, but that hasn't been the case. And they overpromised and underdelivered on that. Just to share some data with you of what we see across the country, we find that there are still, believe it or not, 35% of practices who still use a paper super bill. I'm sure you remember that from years ago. There are still 35% of the practices out there that are using that paper super bill. But what we see even more commonly is that practices have just shifted some of the work. Yep, they're not doing manual charge entry. They're not keying off a paper super bill anymore, but their coders, their billers are spending more time correcting physician mistakes downstream, right? So that's where we see one of the big challenges. Let me go ahead and launch another polling question real quick. Just asking about meaningful use's impact on your revenue cycle. Which of these three answers best fits your practice? No change at all for us. Our doctors still use a paper super bill, so from a revenue cycle perspective, meaningful use was no change for us. Others, and probably more of you, your doctors are using EHR templates. But the question is that saving coding time, or your doctor's using the EHR templates, but you're actually spending a lot of time on coding review? So I'll give everybody another 10, 15 seconds to lock in those answers, and then we'll share the results with you as well. All right, so what I'm seeing is the early results, at least in combining that with our data from the previous webinar, a pretty small percentage, about 25, 30%, what we would expect to see. Practices are still using that paper super bill, but everybody else, I don't have any answers that says the EHR templates are saving the coding team a lot of time. So the majority of people, 75, 80% of practices say, my doctors are using the EHR templates, but we are spending more time on that coding review process. So what we see is there are a lot of revenue cycle opportunities out there, right, for practices to be able to deliver revenue cycle improvements where meaningful use never has delivered. That's what we work with a lot of orthopedic practices on. If you want more information kind of about our products and our services and how we do that, certainly happy to share that with you. Just let us know in the questions panel, and we'll make sure that we get you some information on that. So when we look at that first response that people have, leveraging those EHR and PM platforms, very high EHR implementation rate, very low EHR replacement rate. So most people have their system, most people are not going to change, and the practices that are doing the best are the ones who say, nope, we're not changing right now. I'm not going to spend time looking at that or waste my energy on that. I'm going to get a better return on investment from optimizing my system, from figuring out how to make that work, right? That protects my investment in my EHR. It improves my revenue cycle outcomes on my current platform. I don't have to switch, right? And that lets me focus on operations improvements for my practice, not chasing government mandates, right? That's the best thing about the meaningful use era being over. You can get back to things that make sense for your practice. All right, so number one thing, leveraging existing EHR and PM platforms. Number two thing we've seen, the response from top performing orthopedic practices are revenue cycle analytics. They want to look at biller and coder productivity metrics, right? If I can't measure that internally, how can I benchmark that externally? I don't want this metric to be able to beat my people over the head with. I want this metric so that we can make our people better, so that we can share knowledge, we can share resources. I want to be able to drill down and see what's happening. What type of changes are we making? What type of changes am I making by coder, by doctor, by payer? And ultimately, at the end of the day, what I'm after are shared best practices. This process doesn't have to be frustrating. It doesn't have to be where all of the knowledge is locked up in your best coder's head. And if they walk out the door, that knowledge walks out the door with them. The frustration that we hear from a lot of administrators is the revenue cycle seems like a black box. I know what comes out on the back end, but I don't know what happens during the process. I don't have visibility to that part of my revenue cycle, and it drives me nuts. And if I don't have visibility to it, I certainly can't benchmark it. And I've got great people on my team. They want to do good work. They care. They're engaged. But I know that we've got turnover risk. If they win the lottery, if they get a new job, they get hit by a bus, pick your metaphor. But if I lose that person, a lot of the detailed knowledge of our coding process and workflow, I don't know how to replicate that because I don't have visibility to it. So let me tell you a story. The names are changed to protect the innocent, right? But this is real live data from a client who had two coders on their team, Alice and Barbara. Okay. Now, when they looked at this, some of the things that the practice could measure was how many encounters Alice and Barbara would process on a monthly basis, right? And you look at that and you say, well, Alice does a little bit more than Barbara, right? But at a surface level, it doesn't tell the whole story. So one of the metrics that we've helped create for our clients is looking at a productivity metric that looks at encounters per hour per coder, or encounters per hour per biller. And when you start to look at that, you see that Alice is 40% more productive than Barbara is. When you drill down a little bit deeper, we see that Alice is actually having to make changes on 52% of the encounters. You know, post-encounter coding, not turning the doctors into a coder, but Alice is actually adding a modifier or changing the way a diagnosis and CPT coder linked, or the doctor marked a major joint injection when it was really an intermediate joint injection, or this payer doesn't allow me to do 2 line items with LT, RT, and that payer wants it on a 50, making those types of changes on 52% of the encounters. And Barbara is right in line with that. She's making changes on 56% of the encounters. So I look at that and I say, well, gosh, I don't need to beat Barbara over the head with a club. What I need to do is figure out what are the secrets to Alice's success. What does she know that we can help Barbara with in our process, in our workflow? Because if I can get Barbara up to her level of productivity, I just got a half a day's worth of time back on my team every week. How am I going to staff up when I've got to start doing more work on HCC coding, or we need to take some of the work off the nurse's plate on some of those prior auths? If I can make my team, the coding team, more productive, I can do that without hiring a new person. And that's a huge opportunity. It's something that we work deeply with our clients on. We typically, just to give you an example, we typically engage with our clients once a quarter to review very, very deep data on those revenue cycle analytics. It's data that comes out of our application. And we're able to see what types of changes are being made, who's making them, when are they making them, what the productivity metrics are. And across our entire client base, here's what we've seen. We've seen across our entire client base, beginning of last year, the average ExcellaSmart, that's one of our applications, the average coder could process 107 encounters per hour, which is awesome. Most people, before we start working with them, are in the 25 to 30 encounters per hour range. So our clients are nearly 4 to 5 times more productive than their peers who don't have our application. But what I'm really proud of is over the course of 2018, that average went from 107 encounters per coder per hour to 141 encounters per coder per hour. That is a 40% increase in a 12-month period of time. And it wasn't because they had additional software or additional tools. It was just they were able to use the data to make their existing employees even more productive than they were before. And that is a huge win for an orthopedic practice that is facing these types of headwinds in the revenue cycle space. Okay, I'm going to launch one more polling question just while I'm talking about encounters per hour. And the question is for you, how many encounters per hour do your coders process? Again, you can only choose one, less than 50, 50 to 75, 75 to 100, more than 100, or you may not know. It may not be something that you're tracking today, or maybe something that you're tracking that you don't know off the top of your head. So if you don't know, go ahead and hit not sure, and we'll share those results as well. I'll give you about, I don't know, 10 more seconds to lock in those answers. All right, early results, what we're seeing is most people, most practices are not sure. They're not tracking this today. About 80% of practices are not tracking this today. The remaining 20% are all in that less than 50 bucket, right? So what that tells me is most people on the webinar today are very similar to the people that we're running into in the market. You're not alone. If you're in that less than 50 bucket, you've got good company. And the people that are not sure, most people are not tracking that metric today. It's a very difficult thing to track without that type of software. If you're interested in trying to calculate what that is, we do have a little tool, free. It's available online on our website. We can get you access to that. It basically lets you put in some of your information that you probably are familiar with, total number of encounters and total number of coders, that sort of thing. You can use it kind of on your own. So if you're interested in that, want access to that, just let us know in the questions panel. We'll get that information to you as well. It's a neat little tool that's available on our website. Okay, so we talked about biller and coder productivity. That's a big one to look at. But we also want to ask questions about what types of coding changes are we making. Right? That's a next level question. Which ones are we making most frequently? Are there opportunities for training for my team on that? Right? Alice does it one way, Barbara does it another way. The data lets me see that so that we can standardize that practice across my team. That makes it easier to plug and play a new coding resource if and when I do have turnover, right? And 75% of you are expecting to have turnover in the next 12 months. The last thing that allows us to do is to share best practices, right? Orthopedics is our #1 specialty for single specialty practices across our client base. We work with close to 2,000 orthopedic physicians across the country, and we're able to actually give you that broad experience based on what we've seen in other practices. There's value in that of learning what some of your peers, some of your colleagues are doing, and how to put that into place to drive the best revenue cycle outcomes you can for your particular practice. Okay, so when I'm looking at the response that we see in the face of these challenges by top performing orthopedic practices, the first thing we see is revenue cycle analytics. The next thing that I see is revenue cycle automation, right? And the first thing that people are doing within automation is they're trying to go beyond exception-only coding workflow. And most practices don't even have that. What we find is most practices, even if you've got your doctors using the EHR templates, most practices have a biller or a coder who are reviewing every single encounter to make sure it was coded correctly. That's why you can only handle 25 to 30 encounters per hour per coder, because they're touching every single one. But we know from the data that they only make changes on close to half of them. So half of that person's time is wasted looking at clean encounters. There has to be a better way. And the top performing practices put in that exception-only coding workflow and then go beyond it to try to automate certain low-level functions. They're trying to maximize both accuracy and minimize staff time. So often the trend, not just in orthopedics, but in the revenue cycle as a whole, across the industry, the trend has been to focus on maximum accuracy and pay no attention to the amount of staff time it takes to deliver that type of outcome. And so as a result, most teams are not nearly as productive as they could be. Right? And that's not their fault. But what we want to do for coders and for billers is to let them spend their time where it is most valuable. Let them spend their time where it's most valuable. Let them focus their coding expertise where it's necessary, where it requires their decision-making brain to kick into action, not just hunting for a mistake, right? So those are the three big areas that we see people trying to get into that space. Let me show you what I'm talking about. The traditional coding review as compared to exception-only coding and revenue cycle automation. Traditional coding review says we're very highly accurate. We don't have a lot of denials coming back on the back end, but it's very high touch. I'm spending a lot of time, I'm spending a lot of resources to be able to generate that type of accuracy. And so when you add something new to my plate, like prior auths or HCC coding or patient AR follow-up, we don't have any bandwidth. We can't absorb that without hiring and adding to our team. And in a declining reimbursement environment, that's very difficult to do. So if you can move to exception-only coding, right, you can get that same level of accuracy, but much more productively. And so the top performing practices are looking to move beyond that exception-only coding workflow to more revenue cycle automation. One example that I saw recently of revenue cycle automation is where I had an orthopedic practice down in Florida, and they had a particular payer that was requiring them to bill out units of their PT charges when they would kind of have an exercise routine that was going on for 45 minutes. They're billing in 15-minute increments. They wanted them to bill that on 3 different line items, each with a unit of 1. And they had other payers who wanted them to bill that on 1 line item with a unit of 3. And they were making that change high volume practice thousands of times a month. Their team worked together with the White Plume team to figure out how they could automate that part of the revenue cycle so that their coders didn't have to stop and look and touch and decide and make changes on every single encounter. And that alone could save them several hours a week of their coders' time that can be reallocated to other workflows that needed their time and attention. So when we look at top performing orthopedic practices that are looking for revenue cycle automation, they're looking to move beyond exception-only coding workflow. They're looking for opportunities to maximize both accuracy and their staff efficiency so that their staff can focus on those items that are top dollar for them. All right, so when I zoom out and I look at this from a 50,000-foot perspective, I want to review what we talked about today, and then I'll try to answer as many of those questions as I can. The reality is that there are significant headwinds facing practices in the orthopedic space from a revenue cycle perspective. There's more work for our billing and coding teams. Declining reimbursement when you consider adjusting for inflation, and turnover staffing challenges that are making those resources more expensive and harder to find. But the top performing practices are responding well by looking for opportunities to leverage their current EHR PM systems, getting visibility into what's happening inside the revenue cycle. What are my coders doing? And how might we be able to automate those types of opportunities? So when you look at that, and I try to put all of that into kind of one final view, it is very difficult to maintain the status quo. The reality is pushing against that and dragging us down. The additional work that's being put on our coders, right? What's happening from the CMS perspective, what's happening in the labor market. That means the average practice is having a really difficult time maintaining the status quo. If you feel tired and worn out because you've been running hard and making no progress, this may be one of the reasons why. But it doesn't have to be that way. The top performing practices are putting in some of these strategies in order to be able to perform even better than they were before. And I've even seen some groups who have gotten so good at this that they think it's a strategic advantage and a net new revenue opportunity for them, where they start to set up their own MSO. They say, we've gotten so good at this process. Our coders and billers are so productive and so accurate that we think that we can do this as another line of business for other practices in our specialty, for other practices in our geography, right? And that's why the gap between the top performing practice and the average practice is growing. We want to help you be on the right-hand side of this slide. So I hope this was helpful for you, gave you some education, some things to think about. If you do have questions or comments or feedback, we'd love to hear that. That's always helpful for us. There's a short 3-question survey once you exit the webinar today. I look at each and every single one of those, and it's hugely helpful for making these webinars better in the future. If you're going to be at AAOE in Nashville next week, we'd love for you to come by and see us. We'd love to share information with you, maybe connect you with some of these top performing practices so you can hear their story as well. But thanks again so much for your time this afternoon. I'll open it up to the questions panel and see if we can't share any of those answers with the whole